We're going to be talking about updates on the management of insomnia, including what we know about dual orexin receptor antagonists in the recent clinical trials. We're going to push through this. We've got another activity at 1:30, so we'll just move right along. We're going to talk a little bit about the assessment of an insomnia complaint, as well as how we use treatments, orexin antagonists among them, to facilitate proper selection that meets the patient's needs. We could talk about the clinical trials related to orexin receptor antagonists. And this takes us right to diagnostic criterion for insomnia disorder as per DSM-4. So you put your sandwich down just for a moment. And if you would indicate whether duration of insomnia 4 to 6 weeks, or exclusion of psychiatric disorder, or insomnia 5 nights per week, or significant distress or impairment are a correct diagnostic criterion for insomnia. Music, please.
You know that I'm proud and I can't get the words out. I wanna be with you everywhere. I wanna be with you everywhere.
So it's correct. It's significant distress or impairment. We're going to look at the criterion next. I will remind you, if you're, again, a student of DSM-5, and by the way, for the gentleman in the back, my next slide is the same as the current slide. I'm not sure why that is. Thank you. Insomnia disorder did not exist in DSM-4 or previous, and it's a recognition that insomnia is often a focus of treatment in psychiatric settings, and deserves its own diagnosis to consistent with the amount of attention that it requires. I was telling during the breakout session to my folks that attended that if you're in an inpatient setting, you may realize that the amount of days that you may be permitted for length of stay is dependent upon the complexity of the cases. And so, for example, if a patient has insomnia disorder as a focus of attention, meaning you intend to assess and treat that specifically, I would recommend putting that on your discharge summary in addition to the psychiatric diagnoses to indicate the complexity of care that you're providing. So insomnia disorder are folks that have trouble falling asleep and staying asleep, but importantly, there are daytime consequences. And so someone that doesn't sleep as well now as they did when they were in 20s, but they're still hitting on all 6 cylinders, that may not be insomnia disorder. So we're looking for some sort of daytime impairment or distress. And you can see those here: irritability, fatigue, and so forth. Insomnia disorder is specific for chronic insomnia. So we're looking at people that have at least 3 nights per week of this complaint for at least 3 months. Importantly, no sleep lab testing is required for the initial assessment and management of insomnia disorder. I will tell you parenthetically that if you have a patient with an insomnia complaint and you've got a good treatment plan, and maybe have to change the treatment plan because the first option is not working, and then the second or third option is not working, and they're still complaining of insomnia, then you would be justified, certainly at that point, in considering ordering a sleep lab test. But it's generally not considered necessary to get sleep lab tests at the first stage of assessment. Insomnia, of course, is extremely common. Half of Americans have an occasional bad night. But for our purposes, we're going to focus on the 10% that have a bad night for months on end, so-called insomnia disorder. It's worth noting that there is a reproducible change in the presentation of the symptoms over the life cycle. Adolescents and young adults are more likely to complain of trouble falling asleep. And when you see anybody, in my opinion, who's between the ages of, let's say, 15 and 25, and their main complaint is they can't fall asleep, you should be very, very suspicious for delayed sleep phase syndrome, which is something a little bit different. And this would be the typical teenager, freshman in college, who, when they're out of the watchful eye of their parents, they've got their buddies now, and they want to watch videos and listen to music until 12 o'clock, 1 a.m., 2 a.m., then they're not getting out of bed until 9 a.m., and they're missing morning classes, and they come to see you. But the problem is their whole sleep cycle is now delayed, so this is something a little bit different. In contrast, older adults may have the opposite problem and don't necessarily complain of falling asleep, but it's staying asleep through the night. This can be because potentially they have advanced sleep phase syndrome, and in the absence of a life partner still at home, they might be going to bed very early and simply can't sleep from, let's say, 8 p.m. until 6 a.m. Insomnia is one of the diagnostic criterion for major depressive disorder, and it includes at least 90% of all inpatients with depression and probably 60 to 70% of outpatients with depression. It has a high positive predictive value. As we discussed yesterday, it's a marker for increased risk for suicide. We have some hope that targeted treatment of insomnia may reduce suicidal ideation in those who are already thinking about that. It's also important to remember that untreated insomnia in the instance of major depression is a risk factor for quick relapse. We also see insomnia in psychotic disorders and anxiety disorders, including, if you again, as Dr. Kaling was saying earlier, if we include PTSD as an anxiety disorder, and certainly generalized anxiety disorder. So it's hard to treat psychiatric disorders without being faced almost with every case with dealing with an insomnia complaint. Once in a blue moon, we'll see patients have a combination of insomnia and hypersomnia. Can't sleep at night and can't stay awake in the daytime. A daytime sleepiness evaluation would be indicated, and this might include early referral to the sleep lab. That is relatively uncommon. If you have a complaint of insomnia, now to the second brown box, without daytime impairment, that may be just a watchful waiting situation. And so, of course, it's the last box, insomnia with daytime impairment, that leads us to do a full assessment. In general, a full assessment for insomnia at the first visit is simply a great sleep history and maybe one or two psychometrics. So that'll take us now to our next audience response question. So presently, what percentage of your patients for new evaluations do you assess for insomnia, at least with a single question? 0, a quarter, half, up to 3/4, 100%. So it's almost 100%, say 100%, and I think that's absolutely consistent with what I would expect would be required. So let's talk a little bit about the special methods, excuse me, to assess it. Apart from a good sleep history, sleep diaries have a purpose. And I think the most important information gained from sleep diaries is not so much the patient's report of how long it took them to fall asleep and stay asleep, but what you learn regarding their behavior. What time are they getting in the bed? What time are they getting out of the bed? Is that consistent or not? Is it highly variable night to night? Are they taking naps or not? And my experience has been trying to get patients to reconstruct from memory, tell me what your bedtime and your uptime has been every night for the last 2 weeks. I can't do that. I can't remember exactly what I did 3 or 4 nights ago. So it's probably unfair to ask our patients to do it. So if you're getting a behavioral history, sleep diaries, which are essentially free, why not give your patients sleep diaries? And as the red line at the bottom says, you have got access to all these tools on your iPads if you're interested in looking at them under resources. Polysomnography, as I mentioned, is typically postponed if used at all, only for failure of your initial treatment plan. But I want to draw your attention to these 4 psychometrics: the Insomnia Severity Index, Epworth Sleepiness Scale, the Reduced Morningness Eveningness Questionnaire, and the Disturbing Dreams and Nightmares Severity Index. All of these are a single page long, have something in the range of 7 or 8 items. It might take your patients 30 to 45 seconds to answer these. They're all in the public domain, and they're all free. The Insomnia Severity Index also is very responsive to treatment effects and is often used as a primary indicator of success in clinical trials. One thing I like about the Insomnia Severity Index is it looks at the patient's perception of how much a problem it is to fall asleep and stay asleep, as opposed to sleep diaries, which are numerical. How many minutes did it take you to fall asleep? How many minutes were you awake in the middle of the night? This is moving away from that and looking at patients' perception and distress, which probably is closer to the mark in terms of what patients care about. The Epworth Sleepiness Scale is what's used typically in sleep apnea evaluations, but it's useful here because we're expecting the sleepiness score to be low. If the sleepiness score is above 10, then you're in an unusual situation. That patient might need a sleep lab test. The morningness eveningness questionnaire tells you whether your patient is a lark, meaning they get up early, or are they an owl? That is, constitutionally, they tend to go to bed very late and get up later. Why is this important? It's important for a variety of reasons. It tells you whether the patient maybe has advanced versus delayed sleep phase syndrome or neither. It's interesting. Recent research, including some from our lab, has shown that if you are an owl, you're at increased risk for depression and increased risk for suicide. So being an owl is not a good thing, generally speaking, and might be something you want to include in your treatment plan to get the patient moved to an earlier schedule, more a socially conventional schedule of going to bed and getting up. And then finally, if the patient doesn't present as a PTSD patient, you may still be interested in, do they have nightmares or not? If you only ask questions about falling asleep and staying asleep, I'm not convinced they're going to spontaneously tell you, and I have bad dreams, nightmares. This is important. Why? Because then you may learn they have PTSD, but through the back door. Or we also know that nightmares are a separate indicator for suicide risk. In fact, it's a more powerful indicator of suicide risk than insomnia by itself. Always worth asking. In terms of how often I repeat these, if I'm seeing a patient where the primary complaint is a sleep problem, I do all 4 of these psychometrics. The only ones I repeat on subsequent visits are the Insomnia Severity Index, if it's insomnia, or the Epworth Sleepiness Scale, if it's sleepiness. Once you've cataloged the patient's symptoms, the severity of their symptoms, you've got a sense of what their behavior is, then it's time to think about treatment. The American College of Physicians and the American Academy of Sleep Medicine says the first-line treatment for chronic insomnia disorder, is cognitive behavior therapy, not drugs. I would agree with them. That's in theory. There are, of course, problems with that. The problems include patients don't necessarily adhere, even under proper instructions, with a behavioral plan. The second is, it may be hard to find a therapist to assist you with implementing a behavioral plan for sleep. I want you to feel encouraged. There's some things you can still do for yourself with your patient, even if you don't consider yourself a CBTI therapist. But I want you to at least be aware that doing something behavioral with the patient is considered first line, if possible. CBTI works at least as well as medication therapy, and it seems to work for long periods of time. But there are a couple of caveats, a couple of areas of weakness in CBTI. The first is time of onset to effect. And if a patient rigorously adheres to your behavioral plan, I think the earliest you're going to see improvement in their insomnia complaint is going to be 1 to 2 weeks out. It will continue to build over a month or more, but it will not be the first night. And certainly in psychiatry, there are instances when we need an immediate result. The patient is begging for immediate relief, and you're concerned that if you fail to provide quick relief, that bad things could happen. So I think although CBTI is a powerful tool, there's still an argument for becoming facile with hypnotic medications. So that brings us now to our medication discussion and an audience response question. Which of the following agents is FDA approved for both sleep onset and sleep maintenance? The music, please.
Lord knows there are things we can do, baby. Just me and you. Come on and pick it up. It's so good. Come on, baby, make it hurt so good. Sometimes love.
So we've got a well-educated crowd here. It, in fact, is Limbo Orexin. What you need to know about Limbo Orexin that you don't know, it's a dual orexin receptor antagonist. It was FDA approved in December. It has not been launched yet. My understanding is there are deliberations with the DEA regarding package labeling, scheduling, and so forth. So for those of you that had not heard of it yet, there's a reason for it, but you certainly will hear about it soon. So let's talk about the drugs that are FDA approved. There are probably 15 or 20, and this is going to go on for 2 or 3 slides, so we're going to go fairly quickly through this. So Istazolam, a benzodiazepine hypnotic, was branded as Prosom. Who has written a fresh prescription for Prosom in the last 5 years? One hand. Anybody else? It's sort of fallen off the map with a few exceptions. Florazepam, brand name Dalmane. Who's written a fresh prescription for Dalmane in the last 5 years? Nobody. Nobody? Back here? One. What we need to know about Dalmane, and there may be reasons why you would in fact prefer it, I suppose, but look at the half-life of this drug. It's metabolized to desmethyldiazepam, which has a half-life in the range of 50 plus hours. That means you give Dalmane tonight, it's going to be with you for a couple, 3 days at least. So I suppose if you wanted a combination hypnotic, anxiolytic, it might make sense, but it's probably not what you want to use most of the time. Quazepam. So anybody who didn't attend my session, you get a gold star if you can tell me what the brand name is for Quazepam. Doral, you are a winner, my friend. You get the gold star. Are you prescribing Doral? You are not. Is anybody prescribing Doral? The reason I'm going through this list is that when we've got 15 plus choices for hypnotic medications, I don't think it's reasonable to expect all of us to be experts and proficient in all these different options. And it's nice to kind of cone these down to maybe 5 or 6 at the most. You're not going to be able to cone it down to 1 or 2. Treating insomnia is a little more complicated than that. It's hard to treat all situations with 1 or 2 options, but maybe 5 or 6. Temazepam, branded as Restoril. I'm prescribing that occasionally, sure. I think there's probably still a place for that. Triazolam, branded as Halcyon. Anybody? Fresh prescriptions? 1. Not too many. The story with Halcyon, of course, it's released in the United States in a 0.5 milligram strength in the 1980s. The UK, the maximum dose was 0.25, and the 0.5 milligram dose was the undoing of Halcyon because we saw in the US a lot of instances of sleepwalking, amnestic behaviors, and so forth. So it may have been fine in a lower dose, but it seems like the water has been poisoned, and so you're not going to see that used very much. And I don't think, if you're not using it, I would say you probably don't need to learn how to use it. Zopiclone, son of Zopiclone. Zopiclone sold in Canada and in Europe. Zopiclone, the single isomer, branded as Lunesta, now a generic drug. Anybody using that? 2. More hands. So this drug has both sleep onset and sleep maintenance effects, has a funny taste in the morning in 20% of patients that take it. Reasonable option. Of course, it has its own side effects. Zolpidem, if we look at Zolpidem, we have 1, 2, 3, 4, 5 options for Zolpidem. Who's using the oral spray? Nobody. Who's using the sublingual wafer? Nobody will admit to that. Who's using sublingual middle of the night Zolpidem? One person. Okay. So maybe you want to be expert in how to using that. Probably not everybody needs to be expert in that. Obviously, I think if you prescribe Zolpidem ever, immediate release, Zolpidem extended release. So I would agree. Those are commonly used medications, and they have a place. Remeltion, a melatonin 1 receptor antagonist. This drug has sleep onset effects, but no sleep maintenance effects. Its most important quality is that it's not scheduled. Everything else I've shown you is a Schedule 4. This is not scheduled, and if you work in a setting where you see addicts in recovery, and about half of them have chronic sleep problems in recovery, and you're thinking, what can I do? Remeltion might be one thing you can do, although it's not going to help with sleep maintenance. Low-dose doxepin, branded as Silanor, sold in doses of 1, 3, and 6 milligrams, which is below the generic capsule of 10 milligrams. Also has the important feature of not being scheduled. So if you had someone in recovery from an addiction, they can't sleep. If we fail to treat the sleep problem, they're at a high risk of relapse. And so low-dose doxepin seems to be a reasonable choice maybe in that situation. And that now takes us to the dual orexin receptor antagonist, Suvorexin and Limbo. So their basic pharmacology is very similar, except their half-lives, as you can see on the far right-hand side, are somewhat different. I think it's too early. I have no opinion yet regarding whether a half-life of 12 versus a half-life of 17 makes much difference. But they're both indicated for sleep onset and sleep maintenance. I'm guessing Limbo Orexin will be a scheduled drug, but it remains to be seen. So let's look at an audience response question. Which of the following is accurate regarding orexins and orexin-targeted therapies? They work by blocking wake-promoting systems as agonists. They work by being antagonists at wake-promoting systems. It's a neuropeptide that only does one thing. It regulates wakefulness. They're located primarily in the midbrain and project to most central nervous system areas, or I don't know.
Soldier on, only you can do what must be done. You know it's some way you're not like me. You're just a prisoner, and you're trying to.
Okay, we've got some honest people here that don't know, and we've got some people that got the right answer. That's block wake-promoting systems. So one way, this is my own simple-minded way of thinking about what orexin does, it is not necessarily the chief wake neurotransmitter. In biogenic amines like norepinephrine, serotonin, dopamine, even acetylcholine are wake-promoting neurochemicals. But orexin plays an important role in maintaining wakefulness, especially later in the day. Look at the figure on the right that shows that the activity of orexin goes up as the day goes along. And so as you begin to burn through your brain fuel, and as there would otherwise be a tendency to begin sinking into sleep, orexin tone is increasing through the day, offsetting that. I sort of consider orexin an arousal supercharger. It may not be the engine itself, but it supercharges the arousal system to keep it functioning when it's supposed to be functioning. Look at the projections of the orexin system. You know, one of the more fascinating things is there are the number of orexin receptors in the brain is measured in the tens of thousands. Very, very few would fit on the head of a pin. And the projections are, for the most part, to arousal targets. The projections don't go anywhere besides relevant locations. For example, in the left-hand figure, look at the cerebellum. There's nothing going to the cerebellum because that's not where the arousal systems are. If I had a similar figure showing you where benzodiazepine receptors were located in the brain, what would that look like? Every inch of this figure would be lit up. So orexin's function is neuroanatomically more discrete, and it's related principally to sleep, maybe somewhat to appetite. But when we think about benzodiazepines or benzodiazepine receptor agonists, what do? Well, they may facilitate sleep, but they're also anxiolytic, and they're also anticonvulsant, and they're also amnestic. We give them during colonoscopies. And they're also anticonvulsant. I've listed 5 things they do. So while I do prescribe benzodiazepine receptor agonists, they do a lot more than simply address the sleep system. Orexin and orexin receptor blockers seem to be tighter in achieving the goal they're trying to achieve. So, I think this is your last question. How confident are you in your ability to evaluate strengths, limitations, indications of dual orexin receptor inhibitors for insomnia? Music, please.
Take me where my future's lying, set them on fire. Burning up.
So sort of a broad range. So we'll look at what is known from the clinical trials. We've got some clinical trials data. There we go. You remember earlier we were talking about tools that were made available to you in your resources, the Insomnia Severity Index, and I mentioned it's a tool that's now often used in clinical trials. And so we see the ISI, the Insomnia Severity Index, in the upper left-hand corner, and a change of 6 points or more is considered clinically meaningful. So we're looking at that with Suvo, as well as Limbo Orexin. Actually, let's see, this is all Suvo Orexin, I apologize, on this slide. And we see the ISI shows change. We also see changes in patient-reported total sleep time, TST, and in sleep onset as well. So Suvo is approved for sleep onset and sleep maintenance. In my breakout session, I mentioned that the Holy Grail of a sleeping pill would be something that puts you to sleep, keeps you asleep, doesn't intoxicate you the next morning, works for a long period of time, no tolerance, no dependence, and is not scheduled, and yet still allows you to awaken in the middle of the night if you're subject to an emergency. The house is on fire. Or you're a new mom and your infant is crying in the middle of the night and you need to attend to the baby. It looks like that might be a property seen in the orexin receptor blockers. And on this slide, we're looking at the effect of suvorexant on difficulty arousing to an 85 decibel auditory stimulus in the sleep lab. And what you see is that patients that take Suvo at 10 or 20 milligrams at bedtime have an arousal threshold not that much different than placebo, which is a good thing. And the same sort of thing has been described in dogs. If we look at Limbo Orexin, the data is presented slightly differently. This is looking at chronic insomniacs in the sleep lab, and now the endpoints are sleep lab endpoints like how long it takes you to fall asleep, that's LPS, latency to persistent sleep, and the zolpidem comparison, the orange dot, is zolpidem extended release, 6.25 milligrams. And what you see is that the Limbo Orexin at 5 and 10 milligrams is superior over 30 days in helping people fall asleep. Their sleep efficiency is better than it would be with zolpidem. And in adults who are 55 years old and older, the same sort of phenomenon are seen. So Limbo Orexin performs at least as well as compared to 6.25 milligrams of zolpidem extended release in falling asleep and staying asleep. Well, what I'll leave you with, because we're about out of time, is again this idea of the Holy Grail and having medications which are effective in keeping you asleep and helping you fall asleep without producing daytime impairment, without producing problems with arousing to an emergency in the middle of the night. This data is from Limbo Orexin. It's already been published in the journal Sleep. And if you look at the vertical axis, you can see the 0 line, which is what's calibrated for placebo. In the United States, no one yet has had the nerve to put people on to sleeping pills at bedtime and then do real-life driving tests on an interstate the next day. The question being is, if you take Ambien at bedtime, are you impaired as a driver at 8 o'clock the following morning? But these studies have been done repeatedly in the Netherlands. There's a group of investigators there that have a lab specially designed for this question, and here's how it works. You put a camera on the back right end of your car, on the driving testing car, pointed at the white line, which indicates the edge of the road. You continuously record video and continuously record the distance between the edge of the car and going off the side of the road. This is then calculated as a standard deviation, or more specifically, the standard deviation from the lateral position. You can see the vertical axis, SDLP, which is a nice way of saying weaving. So is the patient weaving or having a high standard deviation depending upon what drug they got the previous night? So if you look at Zopiclone, which is father of S-Zopiclone, look at the little black box with the lines that shows you the mean as well as the standard error of the mean. And you can see that it's higher than the 0 line, placebo. But look at Limbo Orexin, 2.5, 5, and 10 milligrams. And they are no different than placebo. So I'm going to finish by saying that I don't think we're quite at the Holy Grail yet of having a drug that does all 7 things that I indicated we wanted. But the orexin receptor blockers, because of their discrete activity in sleep-pertinent systems, and the fact that they don't get all over the brain into places like the cerebellum, may mean that they're going to have advantages for things like being able to respond to emergencies in the middle of the night and being able to drive the next morning without being impaired. So I'm out of time, and I have Sherry's going to let me answer a couple of questions. Thank you. 2 minutes, 5 minutes?
About 5 minutes.
5
I'll come
minutes.
back.
Okay. She's going to get us in the end. All right. So the first question is very much to the point. Do you use dual orexin antagonists for insomnia with narcolepsy? And the answer is no. When these drugs were first developed, Suvo being the prototype, there was a concern that if you blocked orexin receptors, you would precipitate the entire narcolepsy syndrome. And this has not happened. And I'll tell you why I think it happens. It's that the brain, like so many other bodily systems, like we can live with only one kidney. We can live with having a lung removed if we have to. We can live with only part of our liver. It seems like we can block most of our orexin receptors without precipitating narcolepsy. It probably requires something close to total loss of function of orexin before that happens, and the blockers don't do that. That's a great question. Let's see. So here's a question, virtual audience question. In my practice, I've had poor results with suvorexin, and it's led me to remove it from my choices, unlike other providers in my area. Have you had a more favorable experience with these agents? The answer is yes, and I'll tell you why I think this is. So this might take the remainder of our time, but it's a story worth telling. You remember when buspirone was approved for generalized anxiety disorder, and it separated quickly from placebo in clinical trials, but it seemed to perform poorly in real practice, especially if you gave it to people who had had prior experience with a benzodiazepine, right, for anxiety. And that's because Buspar doesn't produce that sensation. There's no feeling that goes with the anxiolytic effect. Patients that have taken Zolpidem, and I have to tell you, as an occasional insomniac, I've taken most of the things on that list plus more. So I'm speaking from personal experience. If you take Zolpidem and you try to resist it and don't go to bed within 15 minutes, what happens? You're going to have a problem. My experience is it feels like there's a freight train coming on, irresistible. It's clear that you've taken a drug, right? That is not true with Suvo. My experience says you just fade just right into sleep. It feels quite natural. There's no drug feeling. We did a clinical trial in depressed insomniacs with Suvo, and I told them, don't expect to feel anything. And they all came back, and of course I asked them, well, did you feel anything? And they said, nope. So I think it's important to tell patients, if you're going to give them an orexin receptor blocker, the goal is to help you fall asleep and stay asleep, but you're not necessarily going to have any experiences with that. So are we